Welcome to my YouTube channel. Today we're going to talk about infantile hypertrophic pyloric stenosis. And here, make sure you subscribe. Let's begin. So let's look at the definition of infantile hypertrophic pyloric stenosis. So the last two words mean pyloric and stenosis. So the parts of the stomach are the following. So we have the part of the GIT, upper GIT, we have the esophagus, and we have the stomach, and here we have the pylorus and then the duodenum. So this is the part that we are talking about. This part is stenosis. So the first two words mean infantile. Infantile means infant, and then hypertrophic means that something has multiplied in size and mass. So if you look, this is our normal stomach and our passage. So this is the esophageal sphincter, this is our stomach, and this is the pylorus, and this is the duodenum, and it is normal, meaning the lumen is of normal size. However, when you come to pyloric stenosis, the pylorus is stenosed, that the lumen is narrow, and the reason behind this is because of the hypertrophy of the circular muscles of the pyloric sphincter. So in terms of the incidence, it occurs in 1 to 3 per 1,000 live births, and male have an higher incidence or are highly predisposed to having pyloric stenosis, same as whites, and also firstborn, in addition to twins. So the other risk factors include children who are taking formula milk are also predisposed to having pyloric stenosis compared to those who are having breast milk, premature infants, and cesarean section. So etiology is usually multifactorial, and the first factor we're going to start is environmental factor, that is exposure to nicotine, and this one is usually during the gestation period. The next factor is bottle feeding. Bottle feeding usually enables the child to take more milk in less time, leading to overstimulation of the pyloric muscle or the pyloric sphincter muscles, leading to hypertrophy and therefore having stenosis. The next factor is genetic component, and the last one that we're going to talk about is macrolides. Macrolides, these are antibiotics, and they include erythromycin and erythromycin. So this, when taken by the mother during breastfeeding or by the infants during the first 2 weeks after birth, then they will predispose one to having pyloric stenosis. Associations. So pyloric stenosis is highly associated with esophageal atresia and also maternal erythromycin use. This is via the breast milk, as you mentioned before. So the pathophysiology behind pyloric stenosis will have a diffuse hypertrophy and hyperplasia of the smooth muscles of the pyloric sphincter. This could be caused either by genetics, by the macrolides, or by the environmental factors that you have talked about. This will later now lead to the narrowing of the pylorus with partial and then almost complete obstruction. So if the pylorus muscle has hypertrophy, then we are going to narrow our lumen, and this will lead to partial or complete obstruction. Then the stomach contents cannot easily flow through the constricted or through the narrow pylorus. So in attempt to push forward through the obstruction, then we'll have vigorous peristalsis will occur. In addition to this, you'll also have vomiting that will occur, because if at the distal end we have an obstruction, what normal physics that we will have, it is that the contents will now find another way out, and another way out will be vomiting, and the vomiting will be projectile, as you're going to look in the next slide. So this vigorous peristalsis, you're going to observe it in our physical examination when we are doing abdominal examination. So as I stated before, you're going to have persistent vomiting and dilated stomach curvature. And this dilated stomach curvature, you're going to observe it as an olive mass. And then the infant will develop dehydration because, number one, they're not taking what they're taking as fluids, that is the milk, they are vomiting it. And when they vomit, they are not only vomiting the components that are taken in, but they're also vomiting the components of the stomachs, and that is the HCl, meaning, and the HCl composition is hydrogen and chloric. So we are going to have hypochloremic alkalosis. So the pathophysiology is just a repetition. Pyloric stenosis is characterized by hypertrophy of the circular muscle, as previously mentioned, so that the canal is lengthened and narrowed with pronounced thickening of the whole pylorus. So you're going to have gastric outlet obstruction, and we say the obstruction could be partial or complete, and this will lead to the loss of acid, that is HCl, meaning we are going to have alkalosis. In addition to that, we also have to have hypochloremia, and we also use ions such as electrolytes such as sodium, chloride, potassium, and water. So in the end, you're going to have dehydration because of loss of water, metabolic alkalosis because of loss of hydrogen ions, and hypokalemia. So normal physiology, what have we lost? We have lost HCl. We have lost HCl. So what is the component of HCl? Hydrogen and chloride. In addition to that, we also lost sodium and also lost potassium and water. So right now we are highly dehydrated, meaning in our blood we are hypovolemic. That's number one. Number two, we are alkalosis. Number three, we are hypokalemia. So what is our component that is going to make us regulate all these electrolytes? And our hero will be the kidney. However, kindly note that what will occur next. So this is a very good slide that I've obtained from Creative Med Doses. They usually have very educative and easy to understand pictorial pictures such as this. So kidney is our hero in this case, and what the kidney said is kid is losing so much, I must compensate. Indeed, this kidney must compensate. But before it compensates, it can't compensate all these ions at the same time. Meaning it has to choose one ion over the other. So we already mentioned that you can, if you are writing, you can write the problems currently we have. We said we have hypovolemia. The reason behind this is because you have lost water. We have hypokalemia. The reason behind this is because we have lost potassium. We have alkalosis because we have lost the hydrogen ions, and we have hypokalemia because we have lost the chloride ions. So let's make things clear. For us to absorb water, what will we need? We will need an hormone called the androgen. And the hormone androgen, what will it take in? It will take in water in addition to sodium. But what will we lose in regards? We are going to lose potassium. So I hope that is very clear at now. In the next thing that we are going to, so we already solved the problem of dehydration. So the next thing that we want to solve is the problem of alkalosis. Our blood has metabolic alkalosis. So when we have metabolic alkalosis, what the kidney will do, it will lose the bicarbonate. And for us to lose bicarbonate, we need chloride. So if I don't have chloride, then I'm unable to secrete. It is kind of an exchange. If I don't have chloride and I'm unable to secrete bicarbonate. So right now, I not secrete bicarbonate in the urine, meaning I'll have too much bicarbonate in my blood, meaning it's kind of I will be exacerbating my problem of metabolic alkalosis. So when we see it in terms of sodium, so we are going to have aldosterone is going to absorb sodium in addition to water, sacrificing potassium. Not only will it sacrifice potassium, but it will sacrifice hydrogen. So as a result, you are going to have your urine, which will be aciduria, meaning the components of your urine will have hydrogen and potassium. But in our minds, the components of our urine should have bicarbonate, which you should have secreted so that for us to balance this metabolic alkalosis, but it is impossible for us to secrete this bicarbonate because you don't have chloride. So I hope you have understood. So we are going to have paradoxical aciduria. The reason why we call it paradoxical is because paradoxical is something that you did not expect. We expected us to secrete the bicarbonate, but right now we are secreting hydrogen. So, and what we are not only secreting paradoxical aciduria, but this urine is also small because you already took sodium and you have already taken water. So I hope you have understood. You have understood what is paradoxical aciduria. Paradoxic aciduria, this is just a repetition of what we have talked about. And as we begin, just even to recap, just read the problems that we have. And the first problems that we have, number one, is hypovolemia. And the reasons why we have hypovolemia is number one, we are not absorbing any water, and we are also vomiting. So that's why we have hypovolemia. The next thing we have alkalosis. And the reason we have alkalosis is because we are losing the hydrogen ions through vomiting. Next thing we have potassium depletion, and the reason that we have potassium depletion is because we are vomiting it. And the other one we have hypochloremia. The reason is because it's HCl, one of the components is chloride. So the first problem we're just going to solve, but when we are solving the first problem, it will lead to exacerbating the two problems that we have. So we have hypovolemia. So if we have hypovolemia, then which hormone is going to be responsible to help us in this problem? Aldosterone. And aldosterone will reabsorb sodium, but in When it reabsorbs sodium, we will end up losing the cation secretions. And the cations that we are losing will be potassium and hydrogen. Remember that if we lose potassium and hydrogen, and we already lost it, so it's kind of we are exacerbating our problem. So remember in the previous slide we said when we have already lost chloride, and chloride is important in the absorption of bicarbonate. So in this state that we have already our full problem, we were expecting for us to lose more bicarbonate, and for us to gain more potassium, and for us to gain more sodium and water. So what we ended up gaining was just the water and the sodium, and we ended up losing potassium and the ions. So that's why we are seeing that we have paradoxical aciduria. So the clinical features, as we say, this disease is for infantile, meaning the infants, and it is typically the postnatal age of onset is usually 2 to 7 weeks, and it is usually rare beyond 4 months. So what are we going to observe in terms of vomiting? In terms of vomiting, we are going to have progressive non-bilious, meaning it does not have the bilious, and then projectile vomiting, meaning when the child is vomiting, then it's going to be projectile, and occasionally containing free coffee grounds, that is some blood stain due to altered blood and gastritis in the infant. So in addition to vomiting, this infant will vomit but will still be hungry. So we are going to have an hunger vomiter. In addition to that, if we keep on vomiting postprandial, then we are going to lose a lot of weight and will have failure to gain weight. In addition to that, dehydration, which I've previously mentioned, and the infant will appear lethargic, less frequent to wet nippers, and in some cases also developing sunken anterior fontanelle, which is a very good sign of dehydration. So some infants also develop jaundice, which will be persistent, and then constipation may occur because of little or no feed will get in the intestine. So in terms of examination, general examination, you're going to see the signs of dehydration, which is one of the classical features that you're going to see. And as stated before, you're going to have sunken fontanelle, dry mucosa membrane, molted skin, and sunken eyes, and also the child will be the lethargic. In addition to that, because we have hypovolemia, we are going to observe reduced capillary refill time and cool extremities. So in an abdominal examination, the key to clinical diagnosis, for you to make this clinical diagnosis, is the palpation of hypertrophied pyloric hypertrophied mass in the pyloric stenosis, in the pylorus, in the epigastrium or right hypochondrium. So this is the mass that I'm talking, and this mass is usually thickened, it's usually olive shaped, and it's usually non-tender, meaning it's not painful on palpation. In addition to that, you can also observe gastric peristalsis, and as we said before, and you can also note features and symptoms that may be atypical of in a premature infant. So the differential diagnosis, I wanted us to talk the differential diagnosis before we talk diagnosis, and the first one is gastroenteritis, and in comparison to pyloric stenosis, in gastroenteritis you're not going to have projectile vomiting, but you'll have presence of diarrhea, which we don't have in pyloric stenosis, and we'll have absence of alkalosis, which we have in pyloric stenosis. In reflux, we're not going to have projectile vomiting, and we are going to have absence of alkalosis. In milk protein allergy, we're not going to have projectile vomiting, but we are going to have diarrhea, and in metabolic diseases, we will not have we will not have projectile vomiting, nor diarrhea, and we will have acidosis. So diagnosis, the first diagnosis, when before we begin, you know how we begin here. The first diagnosis is our history, and the next diagnosis is our examination. So if you do those two very careful, by taking the history of the child, what are you taking? Is this child dehydrated? Do they vomit? How do they vomit? Projectile? What is their vomiting? Is it ambulance? Then examination, you examine this child lethargic. Does this child have signs of dehydration, as we have mentioned before? And then when we do abdominal examination, do you see a mass in the pylorus? And can you observe peristalsis among all the factors that you have talked about? So you can also do a test feed, and a test feed is just when you give the baby feed and you're going to observe that olive mass. that is fat on the lateral margin of the right rectus abdominal muscle just below the liver. In addition to that, blood tests, these are very essential, and you can already tell us what you are thinking. You're going to have less potassium, less sodium, less potassium, less chloride, but you're going to have increased urea and decreased creatinine. So blood gas analysis, the pH will be elevated, that is alkalosis. You are going to have increased bicarbonate. Remember when we said we are going to say it will be less to lose the bicarbonate because we don't have the chloride. So the bicarbonate values, so mild will have less than 25, moderate will have 26 to 35, and then severe you'll have greater than 35. So the next diagnosis that we're going to use is abdominal ultrasound, and this is the key or the choice of diagnosis in a child who has pyloric stenosis. And you're going to visualize a muscle thickening greater than 4 millimeters, and normal usually less than 3 millimeters. Pyloric canal length, as you said before, it's going to lengthen, and then this is going to be greater than 14 millimeters, and usually is less than 12 millimeters. And pylorus diameter will be stenosis, meaning it will be small, less than normal. So this is the pylorus. So when I say stenosis is the lumen, but here when you're talking about the diameter, we are looking at the overall diameter of the lumen, overall diameter of the pylorus. So meaning it is hypertrophic, we'll have a larger one, which will be greater than 11 millimeters, and the normal is less than 10. So we can also do other studies, and one of the studies that you can do is barium studies, and what you are going to see is the narrow pyloric orifice. As you can see, we already have narrow pyloric orifice. In addition to that, you're going also to observe the string side. So this is just a question to you: where else in the GI? Actually, this is in the GI. Where else can you observe string sign? Where else? So food for thought. I'm going to tell you when we end. So string side, this is the string, like string. For those who understand my language, Uzi. So string size, this is elongated and thick pylorus, as you're going to observe here. So literally, what this is when you're given the child barium studies is when you swallow in, and then this is how you observe the food is going to travel. So this is the lumen. So that is what is called the string size. In addition to that, you can also observe the big sign, and this is the big sign. However, these signs are not very much specific for pyloric stenosis. So where else can you observe string size? You can observe the string size in Crohn's disease. That is one of the under umbrella of inflammatory bowel disease. And the big sign, there's something else you can see. Bad big sign is common in achalasia. So the management, pyloric stenosis is not a surgical emergency. However, it's a medical emergency, and you need to correct that medical emergency. And why is it a medical emergency? Because we have lost a lot of ions, so we have a lot of electrolytes, and the kidney is not helping us to resuscitate or to go back to normal. So initial resuscitation is very paramount, and what we do an gastric tube to drain off the stomach content and prevent recurrent vomiting, and you keep on the NG tube free of drainage with hourly aspiration. In addition to that, you replace losses for ml from ml, that you can give 0.9 sodium chloride and 10 millimoles of potassium chloride. You can also give intravenous food. Remember what we said, that what are we going to lose? We are going to lose water, we are going to lose potassium, we are going to lose chloride, and hydrogen. So intravenous fluids, we give the fluids 0.9 of sodium chloride in addition to 5% of dextrose. This is for glucose. And then afterwards you confirm the urine output. Blood glucose concentration should be monitored. The blood glucose concentration should be monitored. So most infants come to surgery within 12 hours, but long-standing vomiting needs to be carefully monitored and prepared and stabilized over 3 to 5 days so that the surgery can be performed later. Once the infant blood tests are normal. So you just don't go, as you said before, this is not a surgical emergency. You have to weigh this patient. Are we metabolically stable? was what we brought in, because this patient will come with hypokalemia, hypochondroplasia, dehydrated, meaning we have less water and less sodium. So we have to go back to normal, that we have to balance our electrolytes to be normal. So we can also, after you have stabilized the patient in terms of medically, then you can do surgery, and the choice of surgery is Ramsted myectomy. So the surgery, this slide has a lot of content, but we just go through one by one. So the surgery, you can either do laparotomy or laparoscopy approach, depending on your skill or the place that you are in. Do you in a high resource setting? The surgery that we are going to do is Ramsted myectomy, and the principles of this surgery: the pylorus is held longitudinally, as seen here, and a longitudinal neuromuscular incision is usually made, as seen here, and then the incision can be made by a blade, diathermy, or a laparoscopic blade. And then the pre-pyloric veins of Mayo. This is just a diagram showing us the venous supply. I wanted us to see the pre-pyloric vein of Mayo, so that I don't give you another assignment of coin and ring. You can just check it here. Marks the pre-duodenal junction. So this is the pre-duodenal junction and distal end of the pylomyectomy. So when you are doing the pylomyectomy, you are not going to go distal to this, you are going to go proximal to this. So if you're going to make your incision using the diathermy or a blade or laparoscopic blade, then you're going to start here, moving proximally. Understood? And the proximal incision is extended to the palpable end of hypertrophic muscle onto the stomach. So I hope that is understood. So you start your incision here, and if the hypertrophic muscle ends here, then there is where you're going to end your incision. And a blunt spreader, this is one of it, a blunt spreader or a pyloric spreader, or a pair of mosquito forceps, or a back of the scalpel blade, or a laparoscopic spreader, then squeeze the muscle until the mucosa is seen bulging. So the adequacy of the myectomy, check the adequacy of the myectomy, and also check the perforation can be done by inserting hair into the stomach, the NG tube, and demonstrating passage into the duodenum, or by the movement of the two leaflets independently. This is also called shoeshine maneuver. So you choose what? I think I'll choose the first one, by inserting hair into the stomach, the NG tube, and demonstrating passage of the hair. If perforation is identified, then it's oversewn by a 5-0 absorbable suture and the omental patch sutured over the perforation. So in addition to that, you can also do conservative management, and conservative management of infantile hypertrophic pyloric stenosis is possible, but is usually associated with higher morbidity and mortality than surgical management. So if it is therefore rarely used, and it is used for few cases that may be required, include patients deemed for hostile surgical abdomen. So for example, a patient comes in and they had previous giant exothalmos, so we have an open abdomen, necrotizing enterocolitis is an infection, and patient with severe comorbid that makes the surgery and anesthesia dangerous. So the conservative management consists of prolonged NG tube drainage, replacement of the ongoing losses, that is the electrolyte losses, provision of parental nutrition, obvious, because if pylorus is stenosis, then our nutrition is very crucial in this pyloric stenosis. And trial pharmacological treatment is associated with pyloric stenosis. Because it is hypertrophy and you have a smaller lumen, then you can provide drugs to relax that pylorus. And atropine is thought to relax the pylorus and decrease the time of resolution of symptoms in infantile hypertrophic pyloric stenosis. Parenteral or peripheral nutrition is very important in this patient. Parenteral nutrition, we have two types of nutrition: enteral nutrition and parenteral nutrition. So enteral nutrition is where you use the GI to feed this child. Parenteral nutrition is where you just inject the nutrients into a vein, which could be central or peripheral. So in this case, you're going to use the peripheral nutrition. So as per natural history, conservation management may be needed up to 6 weeks to allow resolution of symptoms. So Post-op care, the NG tube, remove the NG tube after completion of surgery, unless obviously we have breach of the mucosa, and then you continue with intravenous fluids, that is normal saline and dextrose, and then restoration of oral feed after 4 to 6 hours post-op if there is no complication. Then start 25% of normal field 3 hourly and increase as tolerated, and then reduce IV fluid as obvious as you take the intake, so that you cannot overload the patient. And then discharge once tolerated 2 full feeds, usually 150 ml per kg per day, and no any other concern. However, minor vomiting may be expected 1 week post-op. So complications, we have several complications. In the first one, we actually touched on it, in the duodenal perforation. So if non-duodenal perforation, you continue with NG tube, and add 48 hours of IV antibiotics, and you delay oral feeding for at least 48 hours. If you did incomplete myotomy, that did not actually separate or did not give the space to the muscles, then you go in for a relook or a reoperation. 2% usually need a relook. Wound infection, this is when you have infection. Persistent post-op vomiting, this is usually defined by prolonged vomiting for greater than 7 days, and is usually caused by too rapid adjustment of the post-op feeding or residual periodic edema. So persistent and frequent daily vomiting in post-op period may require an upper GI contrast study. So in addition to that, the last one is pyloric stenosis may persist, and that may need a redo. Thank you.